All right, so now that we talked a little bit about neutrophil migration, we're going to kick things up a notch and just talk about some of the pathologies associated with it. There's a bunch of different types of this. I don't want to go into all the details on the different ones. I want to just talk about the big one that you have to know, and that's leukocyte adhesion deficiency type 1. And if you really want to read up on the different types, we can go through that. In step 2, we'll probably go into more detail as it tends to be more pertinent there. So if you have an absence of LFA1, remember what LFA1 did, right? LFA1 was what bound to ICAM1, right? So remember ICAM1, LFA1, that's this binding right here. So you can see there's like an exclamation point right here. If we don't have LFA1, right? If we don't have this receptor to bind to ICAM1, we can't lock in that neutrophil so that eventually can undergo crawling diapedesis and transmigration. We can't do that if we don't have LFA1. Okay, and LFA1, if you go back to that previous video, you'll see in parentheses, there were some CD markers associated with it, but the big one is CD18. So when you think about leukocyte adhesion deficiency, the number one thing I want you to think about off the bat is going to be CD18. This is one of those times where, sometimes it's important to remember these CD markers, other times not as big of a deal. This is one time you really want to remember it. Now remember, if we're talking about macrophages, this would be MAC1. Okay, so MAC1 usually more so on macrophages, LFA1 more on neutrophils. But the big point is you're unable to have a tight adhesion step. So basically from step 3 on, you're kind of in trouble, right? Because you can't lock this neutrophil in. The whole idea was these neutrophils are coming in pretty fast. You slow them down with the E-selectins binding to Sial-Lewis X and possibly P-selectins, right? Then you lock things in with the ICAM1, the intracellular adhesion molecule 1. You lock things in with that. Now, if ICAM1 is there, but the receptor that it binds to is not, well, that's a problem. That neutrophil is not going to get locked in. You're not going to get it to the site where it needs to go. So the problem is by not locking this neutrophil in, it just ends up kind of leaving this area, or at least a lot of them do. And they don't end up going through these later steps to get to the site of infection. Now, if you think about it, right, if you don't get neutrophils to the site of infection, that's going to be a problem. These patients are going to have recurrent infections. We're never going to get to a high level of immunity from certain infections if we can't even get the first responders to the site of infection. So that's why you have these recurring infections. But the most important thing to remember, there's a lot of different diseases that present with recurring infections, as you'll see in this immuno unit. But the big thing here is there's an absence of pus. This CD18 and absence of pus, that's pretty much the most important things that you have to know about this disease, okay? And because this is very unique, right? So if you think about it, like what is pus, right? So if you have, a dermal infection, you say, oh, what's pus, right? What's in it? Well, it's mostly going to be dead neutrophils, right? A lot of pus is really just dead neutrophils. You can imagine, right? If you don't have neutrophils going to your infections, well, you're not going to have them in the pus that's going to come from those infections, right? Because they never got to the infection to begin with. So that's why you have the absence of pus. You have absence of pus because you have absence of neutrophils, okay? And so you can also see impaired wound healing here. And then another big thing, if you had to put in a third thing besides CD18 and absence of pus, the umbilical cord being delayed in terms of its detachment. Very classic for leukocyte adhesion deficiency. So just keep this one in mind. Again, it has to do with neutrophils going to the site, and neutrophils play a very pivotal role in the umbilical cord coming off when it does. CD18, absence of pus, umbilical cord detachment. Now, Shediac-Higashi syndrome is going to have to do with impaired microtubule polymerization. And again, it's really these mechanisms that you have to be familiar with. So if you don't have good microtubule polymerization, right, this can result in a decrease in neutrophil chemotaxis. Chemotaxis, again, interleukin 8, LTB4, C5a, right? Just remember those. Those are your big three. Okay, but this process is impaired. So it's the same concept here. You're just not going to get neutrophils coming to these sites because you're not able to get neutrophil chemotaxis working the way that it should. Okay, so that's the first thing. The next thing here, and there's kind of two major problems, is you have lysosomal dysfunction. Phagolysosomal fusion, remember we talked about you digest the bacteria into a phagolysosome and eventually you're trying to break it down using things like respiratory burst, things that we've talked about already. And so again, there's dysfunction in doing that. And so you get these really enlarged vesicles because you're pretty much just housing components of these pathogens, but you're not really breaking them down. And this is due to a defect in the LIST gene. And so LIST is for lysosomal trafficking gene defect, okay? So again, combination of this impaired microtubule polymerization and lysosomal dysfunction, just some things to remember when you're talking about Shediac-Higashi syndrome. Autosomal recessive, I always tell people, I don't remember autosomal recessive diseases. I remember all of the X-linked dominant, X-linked recessive, and autosomal dominant. Everything else is going to be autosomal recessive. So this kind of just fits in with everybody else. Now, in terms of the presentation, again, recurrent infections. And there's a lot of things, like we said, that present with recurrent infection. So this doesn't make anything stand out from the bunch. However, the things that do stand out are partial albinism. Okay, so if you have a patient that has silvery hair or they're photophobia, right, and they don't like to be in the sun or it's painful for them to be in the sun, and they have a peripheral neuropathy. Again, peripheral neuropathy, think about microtubule polymerization. That's what happens when you start taking drugs like vincristine, vinblastine. You start to damage some of those microtubules, and we'll talk about all of that in the biochemistry section, but those patients can end up with a peripheral neuropathy secondary to chemotherapeutics like vincristine and vinblastine, and paclitaxel is another classic one. That's essentially what we're talking about here. Defects in microtubule polymerization, peripheral neuropathy. The last thing they'll sometimes show you are these giant cytoplasmic granules. You might be saying, well, what do those have to do with? Well, we already said you have these large vesicles, non-functioning lysosomes, and so you get these massive granules in here that are basically representative of that. If you see a cell like this, right, you're like, well, what type of cell is this? Look, it's got 3 lobes. What did I tell you about the lobes, right? If it has about 3 to 4 lobes, start to think about a neutrophil. Unless it's staining pink or dark blue, right? It's usually going to be a neutrophil. If it has 6 or 7 lobes, now you're thinking B12 deficiency, right? Hypersegmented neutrophils. But anyway, I don't want to get too far off track, but that's what you're looking for. You're looking for these giant cytoplasmic granules. So these are the big 2 that I want you to be familiar with.